I'm going to run through each of those work streams, just outlining the aims and giving some examples of some of the initiatives that the NHS itself has put out there to say, these are things that we think can work. Now, one of key interest, I think, here is the evidence that actually supports the cases for those initiatives and interventions. Because it's very important, obviously, that if commissioners and providers are beginning to take up or to start interventions that they hope will achieve cost savings whilst maintaining quality and service levels, that they're not sidetracked into making changes where there's little or no tangible benefit, and particularly when there is a requirement for any initial investment. So all of the examples I'm going to talk about are on the NHS evidence website, so they're not new things in that sense. They all have merits, but there are 6 types of evidence, I think, that we're keen to sort of examine, really, in terms of whether or not these interventions are going to be successful. And these are around whether or not the intervention has been successfully implemented anywhere, whether it's been replicated across more than one organisation or area, whether it's linked to any national standards or guidance, or in fact international standards or guidance, whether it's supported by one or more national organisations, and whether it's had an evaluation of its effects carried out, and whether there are any publications relating to the intervention. Some of the examples I'll talk about don't necessarily satisfy all of those criteria, and NHS bodies will have a difficult choice to make in terms of saving money, and it's vital that they're able to reference robust evidence and make those decisions. So I'll outline some of the factors that healthcare commissioners and providers will need to consider in making those decisions about whether or not these QIP interventions will work. Towards the end, I'll hand back to John, and he'll talk about some more of the work that YHEC has done on some of the QIP areas, and then we'd like to open it up to you to talk about some of your experiences and what the challenges you feel there are for you and your organisations. Okay, we'll start with the 5 commissioning and pathway work streams. We'll start with safe care. This is a fairly straightforward aim, which is simply to reduce or to make care safer through, for example, reduction in pressure ulcers, reduction in falls in care, or catheter-acquired urinary tract infections. One of the examples, perhaps one of the most obvious examples in terms of this, is around the Clean Your Hands campaign for healthcare staff, which has been estimated that there's potential for £140 million worth of savings if a 9% reduction in infection rates could be achieved. It's already being implemented, as most of you will know. There's been a full economic evaluation based on a national observational study, supported by a range of national organisations, and it's been adopted by all acute and non-acute NHS organisations. There are no investment costs needed, so it seemed to us there's some fairly robust evidence for the fact that this is an area that where clear savings can be made while improving quality. Another example in this category would be venous thromboembolic prophylaxis, if you excuse my pronunciation, hopefully, in surgical patients, and the idea about reducing those incidences. This is based on evidence provided by NICE through its clinical guidelines, and it has been rolled out in more than one organisation across the country. Interestingly, with this intervention, full implementation across the country could save up to 5 million, but that is a net saving, so it requires some investment costs. So again, it will be up to NHS organisations to consider whether or not that initial investment is worthwhile in that particular intervention. Moving on to talk about right care. This is really about the development of pathways and networks rather than institution-based care or focusing on the institution. So it's about developing things like programme budgeting and responsibility for clinical quality along different pathways. Some of the NHS evidence for this is around, or an example of this is around improving acute care for major trauma patients, which is involved or is involving a redesign of major trauma care into regionally organised networks. There is plenty of national and international evidence that this will work. There are not yet links to standards or guidance in the UK. But there are estimates of significant savings along those lines, which consist of reducing average length of stays by around 4 days. However, again, restructuring would require some investment, although the amount is not specified as yet in the evidence. I think this morning Amit talked about long-term conditions being, I think he said 70% of the cost of the NHS. I'm not sure exactly what the potential cost is to the NHS, but it's clearly significant. And one of John's earlier slides identified that the Department of Health has already identified that this is one of the key areas where savings need to be generated and improvements need to be made. Now, the aim really is around the implementation of a generic model for supporting patients with long-term conditions at a local level. So, for example, understanding needs and risk management and maximising self-management through care plans and information. As you'd imagine, there are a number of examples of initiatives across the country and internationally that have taken place. I'll run through a couple here. The first is around evidence-based cardiovascular disease screening and treatment, and there's an example from Sandwell where 5,000 new patients were invited for screening, of whom about half took up that opportunity. A high percentage of those were given some form of medication. There were around a quarter of those people were given some form of lifestyle referral. 9 referrals were made to rapid access pain clinics. 120 heart attacks and strokes were prevented, and 40 lives were saved. An obvious improvement in quality and, of course, cost to the NHS. The evidence for this shows that there's potential for around £1 to £2 million worth of savings through prevention, but it would again need around £100,000 to pump prime this kind of initiative. Significantly as well, there's an estimate that there could be up to 10 years for the realisation of these benefits, and it's around sort of the issue of prevention and how long that takes to come through in terms of tangible benefits to the NHS. So again, a decision to be made there about whether or not that is something that people would like to pursue. Another example is the implementation of the NICE hypertension guidelines, which the NHS has estimated could save up to 220 million a year. And again, there is evidence through the NICE guidelines and other local projects. I'll briefly give you a local approach in our, I say our region, in where York is in terms of the York and Humber region. The Strategic Health Authority has published some work around what a practice-based commissioning consortium in Hull has done, based on systematic review research in the BMJ. And the work they've done with COPD patients has, with COPD patients with at least one emergency admission during the year. And they've introduced a bi-weekly contact to try to identify early signs of exacerbation. They've set up systems to flag patients requiring more proactive clinical management. They've put in place patient education and self-management support, and they've established a nurse practitioner forum to share best practice and to provide supervision. And the outcomes that the PCT has seen is that patients on the COPD registers have been reduced by 8%, hospital admissions have been reduced by 38%, and readmission rates are down by 37%. And hospital bed days have been reduced by 44%. And there's an estimate that around £3 million a year could be saved per PCT in terms of reducing emergency admissions. So that's just a local example of one of the approaches to long-term conditions. The pathway around, the work stream around urgent and emergency care is really around guiding patients to the most appropriate care settings rather than trying to educate them as to where they should go in an emergency. And the desired outcome for this is to achieve a 10% reduction in A&E attendances, with also associated reductions in ambulance journeys and admissions. NHS examples for this are still in development, but as I say, we'd be happy to hear from you if you have any examples of those kind of developments in your area. Finally, in terms of commissioning and pathways, we just briefly talk about end-of-life care. The aim of this workstream is to improve systems and planning for end-of-life care, particularly for high-risk groups. An example that the NHS has provided here is through Bournemouth and Poole Community Health Services, which has established an enhanced home-based palliative care service for adults, which has led to, which has established the nurse-led approach, which has led to a reduction in 16,000 bed days and avoided A&E admissions.